Hello, everybody. My name's Ed Pavlik. I'm in Lexington, Kentucky, and we're today going to bring you another edition of Gynok Garage. Uh, we're having April showers here in Lexington, Kentucky. My colleague in London, England is,
Frank Lawton from London, UK, and we've got wonderful weather here. It's going to be very warm. In old money, it's 25 degrees centigrade. So that's going to be, I suppose, that's the low 80s in Fahrenheit. It's going to be marvelous. This is England, so it'll only last a few days, but at the moment we're hotter than the Mediterranean, which is good. And the garden's looking good, and everybody's out and about and wandering around, and the pubs are open, and it's very comfortable, very pleasant.
oh, great. Now, Frank, were any of your paintings in the group of 46 artworks that were accidentally disposed of in the Netherlands, including
No,
Andy
they're
Warhol?
all still here. Here they are, Ed. None of them have moved. Yes, I must be very careful if I ever submit my any of my paintings to that gallery that they end up in a dumpster somewhere. Clearly a mistake, and obviously somebody just thought it was a piece of paper. But poor old Andy Warhol, it's probably worth many thousands of dollars as well. Even if it's just a print, it's going to be, a signed print is worth a bit when you've got Andy Warhol's signature on it.
Well,
Never mind.
I hate to be one of the public works people trying to empty dumpsters. There's probably tons of people wanting to go through them before they get to be dumped.
Yes, yes. Oh well.
Okay, well, today we're going to consider the question, does CA-125 at the time of diagnosis vary by ethnicity? An approach to this question is answered in a paper in JAMA Network Open. The title of the paper was Cancer Antigen 125 Levels at the time of ovarian cancer diagnosis by race and ethnicity. And race and ethnicity are different. Race is really sort of the phenotypic version of things, like skin color, where ethnicity takes into a variety of cultural factors in addition to that. Well, Frank, take it from here, please.
When I first saw this paper, I was quite interested in it. The obviously when Bast et al. Introduced the monoclonal antibody OC125, CA125, most of the implication is that the study was done on essentially on a white population because that is where the environs of the hospital where it was carried out. It was never mentioned whether they were whites or not, and there has been a number of papers over the years looking at CA125 levels based on different ethnic groups. And it's not any particularly news that in Afro-Caribbeans, Asians, American Indians, CA125 levels are lower. So what this paper has done is looked at CA125 levels at the now they call it at the time of diagnosis. Now, I'm not sure whether that means when the patient first attended a physician with symptoms, because clearly they've not been using CA125 as a sole screening method, at least I hope they haven't, or whether or not this is when the patient was first referred to a GYN oncologist with signs and symptoms of ovarian cancer, or indeed when the patient first had the laparotomy and the histology were available. So I'm at a loss to know when the CA125, this signature, the index CA125 was taken. And indeed, if a group of patients with a normal CA125 who remain symptomatic, who have a pelvic mass, presumably they've had more than one CA125. So which one are the authors collecting as the index CA125? The result of their study, their primary outcome, that American Indians, Asians, and blacks in America are 23% less likely to have a raised CA125 at the time of diagnosis. Why on earth they didn't actually just put the numbers down rather than 23% less likely? It's almost like they're trying to hide something, possibly something that is actually not that important. Um, and if also, again, if the CA125s were within the normal range, and which 23% of them are, what prompted the patient to attend a GYN oncologist and have the surgery? Was it the fact that they continued with pelvic symptoms or what? So that's the first problem I have. The other thing, it's quite interesting that in one of the tables they show that the less likelihood of having a CA125 before diagnosis is less. So that it's less likely to be carried out in non-whites, in young patients, in patients with no insurance. I think we can understand that. Patients of lower educational achievement and in academic centres. Now, academic centres are less likely to carry out a preoperative CA or pre-diagnostic CA125. Seems very odd to me. Where those statistics come from, I don't know. The second outcome of this paper is the delay, that if a patient at diagnosis has a normal CA125, then they've recorded a delay in treatment of 9.38 days for patients who found to have stage 2 to 4 epithelial ovarian cancer. I don't think in the great scheme of things, 9.38 days is important. It may be important to the patient, but I don't think the patient would know that there's a delay particularly. So a delay of a week and a half in treatment in a tumor that has a doubling time of 40 to 50 days, possibly even longer, I don't think is important. The numbers are tiny. Anything that this paper is saying should be addressed. I don't think that the medical fraternity would get too many sleepless nights over this. And the other thing is that they say that if the CA125 levels were updated, and quite a number of papers have suggested that 35 units per mil is too high. In the UK, it's been reduced or suggested it should be in the upper 20s, same in Canada. In Japan, in a couple of papers, they've been less than 10 in order to, but of course, if you increase the sensitivity of your test, the diagnostic ability, then you decrease the specificity. You're going to get a hell of a lot of patients coming in with nothing wrong with them. And in the end, they say that if the levels were updated, they would save the lives of, would be diagnosed at an earlier stage in 60 patients in the United States of America and 1,500 worldwide. That's peanuts. That is of no significance.
Well, plus Frank, CA125 is notoriously ineffective for early stage disease, which they propose would be something that could be achieved.
Yeah, there's the CA125 alone is not a screening test, and they, as I say, I don't know what finally got these patients to surgery. If it was continuing symptoms, then presumably they had more than one CA125. If it's the fact that pelvic imaging actually revealed a mass that was suspicious, then the CA125 level was not relevant to those particular patients. It's not a very important study, I think.
Sure, and I think I'd point out that even if there was a racial explanation for not being able to see CA125, these people apparently received expedient care. I mean, it really did not have a consequence. So,
Yeah.
well, one thing that I'll point out about this paper, and it's true about anything that people read, is they look for a reason to keep on reading. And table 1 in their paper, I think, was presented by the authors as that reason to keep on reading. And this is what it really looks like. And they point out, and hopefully my cursor will show you this, is that this difference right here between 85% and 9 or 10% is like a difference in detection. This column right here is the elevated CA125, and so they're saying there's a real difference here, just for blacks and whites, but also for the American Indians. I sort of said, well, that is impressive. I should continue reading. And after I read it and everything, I saw at the end, which we'll see in a second, that the difference on odds ratio is relatively tiny. And then that took me back to the table 1, and the table I'm looking for, is right here. Once again, as you said, Frank, it's a 23% reduction that they claim to occur, and on a percentage basis of what they're looking at, we're looking at relatively nothing. And then the delay to chemotherapy is relatively small. Now, the sort of the math of why that first table was so intriguing to me is really sort of explained, by this slide. And the deal here is that if you normalize by the top yellow shaded figures, you will get what they gave us as an explanation for doing this work. And to tell you the truth, that's quite impressive. You're seeing that those who are positive for CA-125 in the white population much greater than in the black population. But you have to realize that we're talking about a distribution of people. It's shown by red here in this population of 250,000 that they're examining. And that's going to be played out in each one of these columns. So that if you normalize in the bottom table the same data by the people who are in the American Indian group versus the Asian group versus the black group, using these numbers here, what you see is that there is no rise or fall basically in the black population or the American Indian population relative to the white. It's roughly around 65, 70% are positive for CA-125 when you normalize, basically by the group. And this says to me really that the phenomenon that's being reported here really doesn't, jump out at you. It's, I think if the authors were here, they might claim, well, we have other evidence and we've done all these other things. But, in the end, the differences I think they show are not large enough to do anything. And, I would go back to the CA-125 population. 20% of them are always going to be negative. The people who are going to be diagnosed with ovarian cancer, only 80% of those will have a CA-125. So, that 20% should be really the thing that we measure everything against. That should be the number that we expect to be negative. And of course, in this group, it's much less than that. And I find that curious.
Mm. Yes, I think that's a very good point. I think that the the fact that they've done the odds ratios rather than actual numbers and actual levels, I think would have been much more important and much more interesting. As you say, a quarter of a third of the 20% of the population have a negative CA-125, and it doesn't matter your ethnic origin. I think that's what it's going to be, and I think it's not as. I still don't know how these patients ended up having surgery if their CA-125s were normal. There's more to it than that. They've not just used a CA-125. And if they've ignored the fact that they were referred for pelvic imaging, then that's even a further problem with the paper. These people ended up having appropriate treatment for ovarian cancer at an appropriate time compared with the white population. Their outcomes were very, very similar. What's the problem, I think?
Absolutely. Well, we can put this one to rest. We don't want to stray too far into saying bad things about it. We've said enough bad things, the way I look at it. Well, we've done this one, Frank. I
Okay.
look forward to doing the next one.
Okie dokie.
You take care.
Thank you. Bye. See you soon.
Okay.